Welcome to those people who have joined. We're just waiting to see if more people are coming on board. Seems to have stopped there. Okay. Good evening to those who have joined us. We're getting a few more coming. I'm Dr. Catherine Stewart, a GP in Bathurst, who also works with the PHN, so I'll be your facilitator tonight. We did have quite a large number of people, so there may be sort of people joining us throughout the webinar, and I may go back and just repeat some of the things we've already said. I would certainly like to acknowledge the traditional custodians of this land. I'm speaking to you from Wiradjuri country, and I certainly warmly welcome any First Nations people. With any webinar, I'd just like to start with our housekeeping. We have had an absolute record attendance tonight, so because of that, we do keep everybody on mute and just let our speakers have their microphones on. However, certainly for the whole thing, but in particular for Dr. Butler's talk, he's very keen, very happy to have questions. So you'll notice down the bottom of your screen, you've got a Q&A section, or there is the chat function. If you put your questions in there, then I can put them to Philip. Just to let you know, the webinar is being recorded, and if anyone wants a copy of the webinar, you can get that. And if you want copies of the slides, we can check with our presenters. So we've got two parts this evening to our presentation. The main part that we'll get to later is the talk from Dr. Philip Butler, who many of you know as a staff specialist, physician and geriatrician in Orange. He's, you can read on the screen there, everything about him, but certainly done most of his work rurally, and which I think is excellent, as well as doing the geriatric medicine. Also does all his general medicine on call as well. Before we get to that, we are going to have a little section. Many of you may have started to hear a bit about health pathways. I certainly know as you get registrars coming into your practice that they will be doing using the health pathways from the hospitals that they've come from. So it'll be good to learn about our local pathways. So who we have joining us tonight and speaking, the program team is Sophia Toole, she's the Health Pathways Manager, and Jessica Ray's the coordinator. The people from the clinical team who we have talking to us tonight is Dr. Ivy Chua. She's the Senior GP Clinical Editor, so sort of overseeing everything. And then Dr. Irene Lavella Soriano is specifically looking at the cognitive impairment pathway. So she'll talk to us after Dr. Butler's talk. So what I might do now is hand over to Sophia to tell us more about the health pathways. Thanks, Sophia.
Great, thank you. So good evening, everybody. My name's Sophia. I'm the Health Pathways Manager for Western New South Wales. So tonight I just wanted to introduce health pathways to those who aren't familiar with it and discuss the cognitive impairment pathways that we are releasing over the next couple of weeks. Next slide. So for those who aren't aware, Health Pathways is a web-based portal health information site which helps guide clinicians through complex local health systems. We aim to provide support in assessing and managing patients with clear referral pathways for patients to general community and secondary care services. We are developed, so Western New South Wales Health Pathways are developed by our local health professionals and is available to all clinicians. So our aims for Health Pathways are to ensure patients are receiving the right care in the right place and at the right time. We aim to build collaboration, enhance clinical knowledge, promote best practice, provide access to medical advice and support, and we also aim to identify appropriate referral pathways, act as a communication interface, and we also aim to contribute to quality improvement and accreditation practices. So Dr. Catherine already went through our team, so I won't go through that again. Tonight we'll be talking about the cognitive impairment pathways. So Dr. Irene Soriano, she has been writing these pathways. So the ones that we are implementing are the following. So behavioural and psychosocial symptoms of dementia, dementia and cognitive assessment, driver assessment of patients with cognitive impairment, medications for dementia, and will also be included the associated request page to look at specialists and support services. So the types of information that will be included on the pathway will include a background on each condition, assessment which incorporates clear steps to take during consultation, management and appropriate escalation pathways, and request pages to direct clinicians in the right direction following consultation. So just a little bit more information about our request pages. So these will incorporate local services such as geriatricians, clinical nursing and associated services, assessment services, and My Aged Care. And request pages will also incorporate criteria for clinicians to follow when referring patients. So just a quick reminder that our COVID-19 pathways are still live. They're still on our website, and we have up-to-date information, including information on the 2023 COVID booster. So quickly, I'll just run through some of the other pathways that we've got in development at the moment. So we're working on the Aboriginal and Torres Strait Islander health assessment, antenatal first visit, ambulance referrals from GPs, certification of death. We're working on some diabetes pathways, which include diabetes education, acute and non-acute diabetes assessment, diagnosis and screening, guide to general practice MBS items, immunisation, opioid replacement pharmacotherapy by an accredited prescriber, SafeScript electronic prescribing, which that one is live. So this is just a quick QR code for those who want to use it. There's a flyer. So the QR code will direct you to a flyer with information about health pathways. The login details are also on this flyer if you want to access them at any time. And these slides, we can share them with you as well with the login details. I'll just take a second for those who want to scan that. That's right. And then this next QR code, this one's going to direct you to the Western New South Wales Health Pathways homepage. And lastly, before I finish, I'm just going to pop a, just wanted to gauge whether people are interested in receiving updates for health pathways. So if we have any new live pages or major updates on existing pages. So what I'll do is I'll just pop this survey in the chat. And if anyone wants to access the survey, just click on it and let us know if you wanted to receive monthly email updates regarding our future pathways. So I'll just pop that in there. And I'm going to hand over to Dr. Ivy Chua, who's our lead clinical editor.
Thank you, Sophia. I will share screen, Liz, if I can have control of that. There we go. I hope that's showing up. So I'll just take you through a quick Cook's tour of the practicalities of navigating the Health Pathways site. Those of you who are familiar with using it for the COVID-19 information, you know, it's continuing as is. But basically, when you log in first up, you'll get this home page. And you can see right in the middle of that home page there are pathway updates. And that's where we'll post when there's new pathways being published live, or if there's significant changes to pathways that are existing on the site. On the left here is the index, basically, and you can see that there are some greyed out sections. You can actually open those greyed out sections, but I just warn you that that's actually information. For example, if we look at child and youth health, those things are actually pages that are not adapted for Western New South Wales as yet. Most of this content has been written in Canterbury, New Zealand, There might be some snippets of information which you find useful, however. What you'll notice though is that the pathways that we have localised for Western New South Wales are in black in the index section there. And, you know, for example, at the moment, vaccination, that's just been updated with COVID-19 vaccination to include our most recent recommendations around the booster schedule. So that's just that left-hand side there. Just point your attention or draw your attention to these things that are called requests within Health Pathways. It's really the fancy name for referrals, referrals to services or referrals information. The concept is more so around that really. What we're doing is not referring and handing on the care of our patients, but we're simply requesting assistance from another health provider in relation to patients' care. So that's the lingo with Health Pathways referrals. They're called requests. And each of our pages that we upload in time to come will have an associated request page that tells you service information and how to contact those services, how best to get patients into those services. I'll also let you know about this blue feedback button here at the bottom. So every single page will have a send feedback button, and really encourage you to use that. If there's any content within any of these pages that you think needs adjustment, or that you're aware of further information that will be useful to upload, just click on send feedback, pop in your email address. It'll take you then to, click on next, it'll take you then to a free text box that you can insert your feedback. And last but not least, I just wanted to show you this search function up here as well. So if you have a particular topic that you want to find out about, basically it's like Googling within Western New South Wales Health Pathways. So for example, if I want to find out about e-scripts, let's type that in there. And it'll take you to the list of pages, and this one only comes up with one result, but takes you to the page then that's relevant to e-scripts for that one there. So electronic prescribing showing up. And you'll see that each of these things that are in blue, you can click on and it will open up text boxes, dot boxes with further information, or will take you to a particular link that's relevant. So that's probably enough for me, but it's very simple to use, designed to use at the point of care. You'll note that it's not written as a textbook. It doesn't plan to have all the Harrison's textbook of information in there, but it's very much about having a set of guidelines which are usable at the point of care when you've got the patient in the room with you, and that will help you with local information that can be put into action straight away. So I will stop there and hand over to the next person.
Thank you very much, Sophia and Ivy. I can tell that they're going to be very useful and we'll all get used to using them. So we are going to start our presentation with Dr. Phil Butler. For those of you who joined us a little bit late, Phil's going to give his presentation. You are all on mute, but he's more than happy to have questions. So if down the bottom of your screen there, you've got the Q&A and the chat. So if you can type in there and I'll put those questions to him. So Phil's speaking to us, as you all know, about the problems and pitfalls in dementia diagnosis. And judging by the number of attendees, it's certainly a much needed topic. So we'll get Phil to share his screen and hand over. Thank you very much.
Thanks very much for the introduction, Catherine. Can I just check that the slides have appeared on your screen?
Yes, they have.
Excellent. So I guess I was asked to give a presentation some time ago, and initially had thoughts about making it about diagnosis of dementia in general, but the more I thought about it, the more I thought, well, actually the most interesting part of this topic is when things are difficult and not straightforward. And unfortunately, as the years have gone by, I've become less and less confident doing what I do. And I've accumulated a long list of all the ways that things can go wrong in dementia diagnosis. So I thought it might be helpful to share some of the things I've found difficult in diagnosing people with dementia, because I think increasingly it's going to be very topical. Demographic factors mean that there will really be an avalanche of people with dementia, particularly in our region, in decades to come. And that will particularly affect smaller towns. I see Dr. Akiwu from Grenfell is online. Towns like Grenfell currently have 30% of their population over 65, whereas the national average is under 20%, and that is likely to become more stark with time. So this isn't a problem for geriatricians alone, it's a whole of health problem, and I guess the more people that are confident in this area, the better off the older people will be. So in brief, what I hope we can get out today is a quick revision of the diagnostic criteria for dementia and some of the challenges applying those criteria in the real world, and to go through some case studies highlighting some problems I've found in dementia diagnosis, areas in which it's not straightforward, and hopefully a bit of a chat and questions and answers about some things other people have found useful in cases where dementia diagnosis isn't straightforward. A few disclaimers: this is not an exhaustive presentation. It's almost the lowest level of evidence. It's not it's a presentation from someone who's been a geriatrician for 5 years, and a lot of this is not necessarily evidence-based. It's from my experience just over the last few years working in my part of the world. It's intended to promote discussion, and it's heavily case-based, where cases have been de-identified, simplified, and altered, hopefully in ways that preserve the main learning points. So I guess to start off with, we need to use a common language when we're talking about dementia, but even that is not easy. Dementia is not simple to define, and if you look back at the last 100 years of dementia research and clinical work, the definition has changed quite a lot. Definition in terms of what its name is and what the criteria are. So there's been DSM 1, 2, 3, 4, 5, and lots of other diagnostic criteria as well. Dementia really is a relatively new term. Previously, there were other terms used to describe people with dementia that are now highly stigmatized. Things like senility, for example, that really aren't used at all anymore, but were used to describe some of the people we would now refer to as having dementia. Most people would agree on what advanced dementia looks like. That's kind of easy, and diagnostic criteria often align well when somebody has advanced dementia. It's really hard to come to a consensus when cognitive and functional impairment is either more mild or subtle or atypical, and that's when you start to get people diagnosed with dementia using one set of criteria but not using another, which is a bit confusing for everybody. So here's an example of a very clear-cut case of moderately advanced dementia that comes from the literature. This is a page from Bleak House by Charles Dickens, and it's a beautiful passage about a husband and wife called Mr. and Mrs. Smallweed, or rather Mr. Smallweed's grandmother and grandfather. And you don't need to perform any cognitive screening tests nor investigations really to be fairly confident that Mr. Smallweed's grandmother has Alzheimer's disease. He's described it perfectly, and it's very unlikely to be anything else. It's also one of the first descriptions of very poor non-pharmacological management of dementia. The grandfather frequently throws a pillow at his wife when she yells out something irritating. So that's kind of straightforward. And most diagnostic criteria would align well with a case like that. Problems arise in lots of different ways, really, with diagnostic criteria. They're often not readily applicable in day-to-day practice. They're either clunky, time-consuming, or or just not practical in day-to-day work environments, even in a geriatrician's rooms. They're not readily understood by patients and families. For example, you might have heard some of my psychiatry colleagues increasingly using the term major neurocognitive disorder, which comes from DSM-5. Patients and families do not understand what that means. And so for that reason, it's not a term I generally use, but with time that may change. Diagnostic criteria heavily oriented towards the research sector. And hopefully one day we have some therapeutic options in dementia that actually work. And when that happens, these diagnostic criteria will probably be much more important than they are now, but that's really not the case at this present time. DSM-4 and 5 in particular are heavily influenced by a psychiatry perspective and not from a general practice community geriatrician neurologist perspective. As I've mentioned before, diagnostic criteria change with time every few decades, which really keeps people on their toes and makes it difficult for clinicians. Ultimately, different criteria means different people are diagnosed with dementia, and I think that's well illustrated on this next slide, which is just a snapshot from a New England Journal article from the 90s. So it's not current, but I think it illustrates the point well. Essentially, they're Venn diagrams of roughly 1,000 older people to whom different diagnostic criteria that were in use at the time were applied. And what they found is that those diagnostic criteria did not overlap. So there's a big pink box with 393 older people that have a diagnosis of dementia made by clinical consensus by experts in the field, and then a blue box with those diagnosed using the DSM-4 criteria. And so there's a whole lot of people who experts agreed do have dementia but didn't meet DSM-4 criteria. I'll touch on what the DSM-4 and 5 criteria are briefly, but we'll move on pretty quickly from those things. So DSM-4 was around from really the 90s onwards, and one area that it falls short really is that there's a strict requirement for memory impairment. Now, there are many people with particularly early dementia for whom their initial journey with dementia is that other cognitive domains might be more markedly affected first, and in fact memory might not be a prominent feature at all. And so these DSM-4 criteria don't really allow for those people at all. And then it requires at least one of the following: aphasia, apraxia, agnosia, and a disturbance in executive functioning. Many clinicians struggle to make a diagnosis of agnosia or executive dysfunction in day-to-day practice. So they're really not useful for many clinicians. And then, as is found in many diagnostic criteria, the crux of the dementia diagnosis is that there's not just cognitive impairment, but it's cognitive impairment that represents a decline from how somebody was previously, and it's impacting substantially, significantly on their function in some way. And there's an exclusion criteria, which is that the setting of delirium cannot be taking place. So moving on to the most recent diagnostic criteria for what is called major neurocognitive disorder, or dementia as everybody else calls it. It's a bit, I think, approaches reality in a sensible way, in that it allows for impairment in domains other than memory, things like learning, language, executive function, complex attention, ability to juggle multiple tasks at once, perceptual or motor dysfunction, impairment in social cognition, such as is seen in people with behavioural variant frontotemporal dementia. And then, similar to the DSM-4 criteria, there has to be impact on function, day-to-day activities, and a decline from a previous baseline. Again, it's important that these features are not seen exclusively in delirium and then disappear when a delirium is over. So just so we're all on the same page, really, common types of dementia, and of course there are others, it's really a short list. So there aren't too many options to choose from. In Australia, at least, the most common causes of dementia are Alzheimer's disease, dementia with Lewy bodies, vascular dementia, and then a few less common things: dementia of mixed etiology, which is more and more common as people get older and are more likely to have multimorbidity. So Alzheimer's mixed with cerebrovascular disease is a pretty common combination. And then Parkinson's disease with dementia, which is often not named as such. It's pretty common for me to meet somebody with advanced Parkinson's disease who's clearly had dementia for several years, but that word has never been used to describe that person's disability and care needs. And then frontotemporal dementia and alcohol-related dementia. I won't go into any detail at all really about what the classic features are of those dementias. It's something that's readily searchable. So some problems that immediately come to mind when using the DSM criteria in the real world are that there's really limited or no access to the gold standard of cognitive assessment, which is neuropsychological assessment. It's almost non-existent in Western New South Wales and really difficult to access in metropolitan centres as well. I've probably sent a handful of patients in 5 years for neuropsychological assessment in Sydney. And what that means is we're often relying on screening, not diagnostic tests, to assess somebody's cognition. And a lot of the time that's fine, but it needs to be done with caution. I use screening tests for diagnostic purposes every single day, but I have to be aware of their limitations. Another problem with these criteria is that it's really difficult to define substantial functional impairment. So that's as a result of differences in what the requirements of day-to-day life are in different settings, and our limitations in taking histories from patients and from reliable informants. So, for example, functional impairment in a working doctor or lawyer or judge is different to functional impairment in somebody who has a less cognitively taxing life, somebody who doesn't often leave the house, for example, has everything done for them, really has only basic things to attend to. A common situation in older people is that there may be functional impairment and there may be cognitive impairment. It might be difficult to tease out what component or part of the functional impairment is due to cognitive impairment and what is due to other physical disabilities. Often that's challenging, or at least I find it challenging. Another problem is that these diagnostic criteria talk about it being important that these cognitive and functional problems don't occur solely in the setting of delirium, but it's not clear in many real-world situations how long one should wait after a delirium to allow somebody's cognition and function to recover. And that just takes experience and getting it wrong really sometimes, and being prepared to make mistakes and having a backup plan. Another just quick point is that a brain injury was historically not thought of as dementia, but it actually is incorporated in these DSM-5 criteria for major neurocognitive disorder. So it kind of makes sense to lump it in with that umbrella term, but it makes less sense to me to lump it in with dementia. And before I move on to some cases, are there any thoughts or questions from the group? No, I'll move on. Catherine, anything from you?
No, there's none there.
I'll push on. Excellent.
Yep. Keep going.
So the first case is a case of dementia diagnosis, which is straightforward because sometimes it is straightforward. In trying to find a good case that demonstrated a straightforward diagnosis, I looked through my letters from the last 6 months and I couldn't actually find one. So this is the only case I've made up. Like you imagine, an 85-year-old woman who lives with her husband. She attends health professionals' rooms accompanied by her husband and daughter. They describe very clearly a slow but steady decline in short-term memory over several years, at least, to the point where she's now become forgetful and repetitive. She's now needing supervision with pills because if that isn't done, there have been times when she's forgotten to take them. Her ability to cook is starting to fray. Some of the meals that she once cooked very well no longer taste so good, and family are needing to keep an eye on things when she's preparing dinner. She's frequently losing things around the house, which, to be honest, is something I do, but she's doing it a lot. And she has some cognitive screening tests, including an MMSE in which she scores 24 out of 30 with 0 out of 3 for recall of those 3 words. blood tests screening for potential biochemical abnormalities that might exacerbate cognitive impairment are all unremarkable. And she has a CT scan of the brain which shows mild white matter changes. So that's a classic picture of dementia due to Alzheimer's disease. And the only, I guess I included the mild white matter changes on the CT scan of the brain because it's really an ubiquitous finding in neuroimaging on older people, and it's of no clinical significance whatsoever. So in this picture, in this case, the clinical phenotype trumps that finding of white matter changes on the CT scan. Really, those white matter changes are only of clinical relevance if they're very severe. Then I'll move on to cases of dementia where diagnosis is not straightforward for a whole host of reasons. So I guess I was thinking about this and trying to structure my talk in a way that made sense to me, at least. I see there are factors that lead to medical attention not being sought by patients and families. That's very common. And I guess the end result of that is often a late diagnosis of dementia, which has lots of associated problems that you would have all seen in your practice. Then there are factors that lead to somebody with dementia, I guess, seeking help or at least being involved in healthcare and engaging with healthcare, but that dementia diagnosis either been not recognised or considered by the health professionals involved. And then there are the group of factors that lead to uncertainty in the diagnosis, even when the dementia diagnosis is considered. So I'll start off with those things that I guess commonly lead to patients and families not seeking medical attention in a timely manner. And I'll start off with a man that I saw a couple of years ago in one of my outreach clinics out of Orange. So it's a 73-year-old man living on a rural property, 1.5 hours from the nearest regional centre, much closer to the nearest reasonably large town, so only 10 minutes out of town. It's a physically robust man with few medical problems at all. He's a Vietnam War veteran with PTSD, which, in a talk about dementia is already ringing alarm bells for many people, I'm sure. He was scheduled to see a geriatrician some years ago, but his partner was unable to actually get him in the car to drive him to the appointment, or rather he'd get in the car, but then would become terrified really that the car was going to fall apart. And so she could only really drive him 20, 30 minutes at most before they'd have to pull over and get out. And so that appointment never eventuated. And by the time I met him in my outreach clinic, he had become very impaired to the point where his MMSE was 3 out of 30. And in fact, his dementia was so advanced that it really wasn't clear what its etiology was, because in some ways, many forms of dementia converge to a similar phenotype at an advanced stage. And that man's care was quite problematic as a result, because the next steps were very difficult. Getting services into the house was very difficult when you ultimately needed a nursing home placement. He had severe BPSD that landed him in hospital for many months. I'm not saying that an earlier diagnosis would have necessarily avoided that, but it may have. Next case is of a 75-year-old man living with his wife in a regional centre. This man is highly educated, multiple university degrees. Again, few medical problems, which I guess is a common theme in people with dementia who have a late diagnosis of dementia. But he does drink alcohol heavily, and that's not something he's sought medical help with. His wife describes the slow onset of short-term memory impairment over 5 years, something her husband had very little insight into. He doesn't have a local GP. He saw a GP in a town a couple of hours away a few months ago to sign off his license, and then never saw them again. And really that was his only engagement with the health service for many years. Similar to the previous man, he's physically robust, which is, I guess, of relevance to his ongoing care needs. So he was brought to medical attention really indirectly when he started to have delusions of spousal infidelity. This is a real red flag for me when I'm triaging referrals, and something I take seriously, because physically robust men who have a delusion that their wife is having an affair really are at risk of hurting or even killing their spouse. So that's one of the few reasons I'm really able to justify triaging somebody as in need of an urgent review. So in response to an argument about the affair he thought his wife was having, he stormed off and drove away. And he was found many days later, almost a week later, hypothermic and delirious 1,000 kilometres away in a remote paddock in rural Victoria by a farmer. He was admitted briefly to a local hospital nearby and had, what we commonly call terrible dementia care in that hospital, when he had physical restraints whilst delirious, and was thankfully taken pretty quickly home by his wife and settled in at home again. Because he wouldn't come in to see me in clinic, I should mention that a referral made its way to me from the JMO at that small rural hospital. He wouldn't come to see me, and I performed a home visit and made a new diagnosis of dementia due to Alzheimer's disease. And this man was quite impaired for somebody who's highly intelligent and educated, with a score in the Addenbrooke's of 68 out of 100, which is pretty terrible actually, and an MMSE of 21 out of 30. And he still refuses to see a GP, has no GP, and his care will be very, very difficult as his dementia progresses. Next case is of another man in his 70s who was transferred to a base hospital from a nearby town. He doesn't have a GP at all. In fact, he's had no interaction with health services for years. He came to attention again indirectly. Initially, police were called repeatedly by his neighbours, worried about him wandering around their front yard, then their backyard, and then rummaging through bins and pouring rubbish through their yard. He was initially referred to mental health services, who were largely unable to take any action because he didn't have a mental health disorder, and he was actually pretty tricky to track down. And he was eventually brought to hospital by an ambulance after his very worried neighbours called police, saying that they hadn't seen him for a while. Welfare check was performed and they found him lying on the floor at home with bruises on his face. We had no collateral history at all about this man. He was estranged from his family, had no friends, so very socially isolated. And it didn't matter what question he was asked, he would say his name in response. So his MMSE was 0 out of 30 as an inpatient in hospital. And he was observed for some weeks in hospital. We had to presume that he might have a rapidly progressive dementia given the absence of collateral history. So he was investigated for that. Nothing was found. And so the ultimate conclusion or consensus was that he had a previously unrecognised advanced dementia of unknown etiology, and that had been neglected or let to run its course in the community, really only coming to attention when things got really, really bad. And so he had to be referred to the guardianship tribunal and is now living in a nursing home in his hometown. Next case, and then some discussion. So the next case is a 76-year-old man living on a rural property with his physically frail wife, is tiny really. And he was referred by his GP with an MMSE of 10 out of 30 with no prior cognitive assessment. A proud and controlling man. His family eventually described the gradual onset of cognitive impairment over 5 to 10 years. So this is happening very slowly and steadily without him wanting to have a bar of talking about it, largely because of insight, but exacerbated by his pride and because of relationship factors, meaning that everyone else was too scared to bring it up. His wife had become really quite scared of this man. Domestic violence and coercive control had been a feature of their relationship for decades. That became worse as his cognitive impairment worsened, and he would not let her talk on the phone to others, and she became fearful of really talking to anybody, including her close family members, about what was actually going on at home because of his paranoia and resulting quite serious physical aggression. So in the end, this man was admitted to hospital in a crisis, and working out what happens next and trying to find appropriate accommodation for him was so difficult that he remained in hospital for many months and died as an inpatient 6 months later. So in summary, some of the factors that I could think of that lead to medical attention not being sought by people with dementia include lack of historical regular engagement with health services or GP, and that can be for lots of reasons. It might be because of personality and fixed health beliefs. It could be habit. It could be because somebody is actually otherwise relatively well and hasn't had a perceived need to see a GP. And all of these things can be driven by or exacerbated by geographical or, for that matter, social isolation. I found that exclusion of concerned family from the consultation room is a pretty common phenomena. This is really difficult to handle when you're juggling a patient's, right to autonomy and privacy with risks to that person and to others, and picking the right time to essentially break confidentiality and to proactively seek or allow collateral history to be given is tricky sometimes. Lack of insight is a common reason for a late diagnosis, and that can be on behalf of the patient and family members, more commonly the patient. I guess health literacy can be a barrier. Not uncommonly, I come across families who are all very much of the opinion that somebody with even quite advanced dementia is just normally aging, and that's normal. And what can be a problem is coming to agreement about what happens next when it comes to things like driving and services and capacity to make important decisions. Fear of implications of a formal diagnosis is pretty common, and the big ones that I see are fear of driving cessation and fear of being put in a home. So I very commonly see somebody who is convinced that I'm going to put them in a home somehow at the first appointment, when that's almost never the case. So I might stop there and just ask the group whether you've come across other factors that lead to a late diagnosis of dementia or medical attention not being sought for problematic cognitive impairment.
So while people are putting that in, Phil, there are a couple of comments and questions that have been made. Jane Lawrence pointed out, which you have there, that lack of GP certainly can be a risk for a late diagnosis. She even thought it might be the cause. We're somehow preventing it with our excellent care. There was a question from Casey Walford. She just was asking around a lot of the cases you've presented are much later, but the early symptoms, sort of how long they can have them for, and sort of what are the, I guess, concerning symptoms that we should be looking for.
I guess I chose some extreme examples of people who have presented late with dementia to illustrate a point. Many of those people had either definitely been declining for more than 5 years or probably had. I'll talk a bit later about people who are presenting earlier on in their journey with dementia. So that I might end up answering that question about early features of dementia at that point.
Yeah. And then Ivy had a couple of questions. One was about when it's quite clear, probably to the GP, to family, that they have, cognitive impairment, but they're able to present quite well to the aged care team, to the specialist, but perhaps to those who have known them for longer can tell that they are having difficulties.
Yeah, that can be difficult. I find that commonly when I have shared patients with some of my specialist colleagues, it can be a shock to find that a shared patient is actually quite markedly cognitively impaired, because it might not be obvious on superficial conversation. And I agree with Ivy's point that that often the best person to identify cognitive impairment is a regular general practitioner who will pick up on subtle things that other people won't have.
Yep. And then she also asked, you might be able to see the question there about, the person with dementia, and then their carer or family member also gets dementia, and when safety's a concern.
Yeah, again, a really common and difficult problem. One of the common reasons for the person who accompanies a person with dementia to be a poor informant is that they are cognitively impaired themselves. And it's really difficult when they're not your patient to try and work out to what degree that is the case. And often it requires trying to get history from somebody else, really. But it's people who are cognitively impaired are commonly married to somebody else who is cognitively impaired. And then safety concerns are common. My personal practice is to tolerate a fair amount of risk if that is what an older person wants, and if that sort of fits in with the way they have lived their life prior to the onset of dementia. Things have to be done, obviously, when there are great risk to others, great risk to that person themselves, or conflict amongst those who love them about what has to be done, and that's where things can get murky and messy. That in the real world, it's often actually quite hard, especially in the community, to intervene and keep somebody safe when they don't want any help.
No, very true. And there was a comment from Jane Kane, who's in Broken Hill. She certainly could relate to a lot of these cases because there are limited access to GPs and specialists there, and also felt that a lot of these rural people are very stoic and proud, and which I think is quite true. One thing that I have found is that we were saying that often the GPs can tell, but I've actually had the opposite situation where I've known someone and seen them so frequently that I might not notice their decline. And so sometimes having someone else like the practice nurse doing formal assessments can bring that out. They're used to talking to me about blood pressure and they know the right things to say.
Yeah, I think that over-familiarity is a real risk. And it's one thing I'd love to be seeing my patients regularly over years, but I'm not able to do that just because of the number of new referrals I'm trying to work through. I have found myself missing a diagnosis of dementia because I had the wool pulled over my eyes previously. For example, an older lady with mild cognitive impairment who was seen for follow-up. I was reassured when she remembered my name, which is something I don't get used to in my line of work, and remembered that we shared the same birthday. And for that reason, I didn't probe her cognition very hard that year. And by the next time I saw her, it was evident she'd probably been dementing the whole time, and I missed it. So yeah, over familiarity is a risk. All right, well, in the interest of time, I might push on to factors that lead to dementia not being recognised or considered by health professionals, even when it's sitting in front of us. So case 6 is an 82-year-old retired doctor with a background notable for substantial anxiety with panic attacks over many decades. She's well engaged with the health system, sees her GP regularly, is a frequent attendee at her local emergency department, often in response to somatic complaints for which a cause is often not identified. Really, she has a lot of health anxiety. On one occasion, she's admitted with dizziness, and during that admission, self-reports declining memory and tells the team that she recently couldn't remember how to operate a garage door, and has, even on a number of occasions, become lost driving around town in familiar areas, or at least areas that were once familiar. The treating team were reassured when she had an MMSE of 29 out of 30. And the thought was, well, she's fine now. She must have had a period of transient global amnesia. She was readmitted to hospital a few weeks later for reasons I don't recall. And during that admission had a long consultation, including detailed discussion of her social and medical history. And during that long conversation, really a picture emerged of someone who actually was quite cognitively impaired, despite that supposedly reassuring MMSE result. So she used a wide vocabulary, as many highly intelligent or educated people do, even in the setting of cognitive impairment. But that vocabulary was really not used in the sophisticated way you'd expect of a practicing doctor or a retired doctor with normal cognition. She was often vague with important details missing. So she might be able to give a simple answer to a question like, tell me about what you've seen on the news in the last week. But unlike what I presume she was able to do 20 years earlier, which would be to give an exhaustive and engaging outline, it would be very brief. And so I was able to, I guess, fairly confidently diagnose her with dementia due to Alzheimer's disease. And the problem there was that her high premorbid intelligence and educational level meant that she was always going to do quite well in cognitive screening tests. And the important thing is that the history always trumps the test. Ideally, somebody like this should have neuropsychological assessment, which would definitely reveal quite marked cognitive impairment that's not evident in screening tests. The next case is a 77-year-old man living with his wife at home in a town a couple of hours from the closest regional centre. He's not a well man and is clearly coming to the end of his life. He has an extensive medical history, which includes lung cancer, for which he has had palliative radiotherapy recently, long-standing COPD, heart failure with an ejection fraction of 17%, atrial fibrillation, and a type 2 diabetes, and a lifelong pretty terrible behaviour, particularly towards his wife, belligerent and often verbally and physically aggressive, as described by his children and by his wife. So he came to my attention after very frequently, 2 or 3 times every single day, every day of the week, presenting to his local emergency department with a range of complaints, things like headache, chest pain, anxiety, I can't sleep, I haven't slept for 2 days, suicidal ideation, like I'm going to kill myself because I haven't slept for 2 days. There were thoughts that he was drug seeking, and in fact, many aspects of his behaviour were drug seeking, in that he would say, I can't sleep, I haven't slept for days, I need X drug to help me sleep. And attempts were made to admit him to try and work this out, but he would often get frustrated and walk out of the emergency department swearing, only to come back hours later. Eventually, he required a planned transfer to a base hospital site for multidisciplinary review to work out what on earth is going on. He refused formal cognitive screening as an inpatient, but in general conversation, a bit like the previous case, cognitive impairment was very evident. So I guess when cognitive screening is nice to have, and most of the time it's necessary, but when you don't have access to it for whatever reason, or it's not helpful, then like listening for evidence of cognitive impairment in general conversation and looking for it that way is, I think, entirely appropriate. And so this man was diagnosed with, I guess, a consensus diagnosis of dementia with BPSD, or behavioural and psychological symptoms of dementia, leading to coarsening of his underlying personality traits. And he ultimately died in hospital and never made it home again. So I guess to cover some of the factors that I've come across that lead to dementia not being recognised, even when somebody's engaged with the health system, is that there might be competing medical problems taking precedence. If you've got a new diagnosis of cancer, or you've got a new diagnosis of clinically significant coronary artery disease or renal failure, that's generally going to take precedence, and it's going to consume all the airtime. So it's difficult for cognitive impairment to come to the fore and be addressed. We talked about over familiarity before. I think that actually is a big problem, and I guess cognitive impairment is often not evident in normal conversation unless somebody is very, very impaired. I've got patients who have a memory that are unable to remember something that happened 30 seconds ago, who, due to preserved social graces and high intelligence, can actually come across as being cognitively normal. It's only when things are probed that their cognitive impairment becomes obvious. On the other side of the coin, underfamiliarity is a problem as well. Attribution of the dominant symptoms of dementia, particularly if they're not classic symptoms like memory impairment, to other pathology can be a problem. And as I mentioned with the case of the highly intelligent, highly educated woman with Alzheimer's disease, being falsely reassured by cognitive screening is a real pitfall in that group. So I probably can't say this enough. The history is key. So I place a lot of weight on the history, particularly if it's from reliable informants and GPs that know a patient well. And if I've got a worrying history with somewhat reassuring cognitive screening results, what that means is I haven't used the right cognitive screening test, and really I need to use something that pushes them a bit harder or tests cognitive domains that perhaps weren't covered in that initial test. And that is, as I said earlier, there are times when really what is needed is not a screening test at all, no matter how complex. What is needed is neuropsychological assessment. But obviously there are problems with that. It requires a trip to Sydney, a stay overnight, being able to tolerate that neuropsychological assessment, which can last several hours, actually wanting to make that trip. So it's only for select people, really. As I mentioned, high premorbid intelligence is a problem. Attribution of poor performance in cognitive screening to poor literacy can be a problem as well. So clearly people who are dyslexic or poorly literate are going to do generally more poorly in cognitive screening tests than somebody who's highly educated and intelligent, but there's limits to that. So it's important to think, well, I've just been told that this person would never have known who the Prime Minister of Australia is. Is that true? That's something I often hear. This person would never have known that. That's something I would never have known. I wouldn't know who that person is either. So just trying to suss out whether that makes sense. And really, that's an area in which knowing somebody serially over many years really helps, because then you're able, as the treating GP, know confidently that there has been a change over time, which is the key to making a dementia diagnosis. And just quickly, there are some cognitive domains that really aren't well tested in any commonly used cognitive screening tests. And the classic would be someone with behavioural variant frontotemporal dementia, who can be hugely disabled by the behaviour resulting from their dementia syndrome, sexually inappropriate behaviour, crazy things done when driving, physical violence, but perform very well on cognitive screening tests that really push people in many domains, like the Adam Brooks. So I'll just pause there in case those cases and those factors have triggered any thoughts from those in the group, or if anybody's got any ideas about things that have led to a dementia diagnosis being difficult to pick up, even when the patient's in the room with them.
Just while we're waiting to see if anyone comes up with anything, I did have two questions. One, you mentioned the neuropsychological assessment being done in Sydney. Are you happy to share with us where you access?
Yeah, so I did much of my training at Concord Hospital, and I'm an honorary VMO at that hospital, largely so that I can continue some professional links with other geriatricians. As part of that, once a week, I present cases at their cognitive disorders clinic multidisciplinary team meeting. And I usually pick a case that's been particularly tricky for me. At that meeting, there are neuropsychologists and multiple geriatricians and dementia nurses. And so that's where I go if I need a consensus diagnosis. It's those neuropsychologists in that clinic that I go to if if I need help in the Concord Hospital Geriatric Medicine Department.
So
But it's really I guess a good example of a very well-run department in a tertiary centre that's provides an excellent service to its local district. It's a research centre, but it's not something that's translated to other parts of the state. So you could live 10 kilometres away and not have ready access to that. So I kind of have to beg and plead to get select patients into that service. Outside, I think for others, it will be very difficult to get a patient into a publicly available neuropsych centre. The exception to that would be patients who are linked in with community mental health teams in Western New South Wales. I know there are several neuropsychologists that work with community mental health, and so that is one area in which people can very conveniently get the assessment they need more locally.
And my other question was, I think as most of us as GPs would use the MMSE. Often when we refer them, they come back with all these ACE and various other things. Would you say there's another test that we could look at, that we could administer moderately easily?
No, I think you just use the test that you're familiar with, that you can actually implement in the time you've got. So really that's going to be an MMSE or a MOCA or a RUDAS, which is what I use when people don't speak English or they're illiterate. So I often use an Addenbrooke's for people who are reasonably literate in my clinic, but that takes 10 or 15 minutes to do. So I don't think that's really practical in a general practice setting. I think it's fine to use an MMSE as long as you're aware of its limits and that you're not falsely reassured by a good number when you're confronted with someone with a strong history of cognitive decline. That's the only thing I'd say about that, but I don't see any problem using it.
Thank you. And just a question there from Casey Walford about age groups dementia can occur.
I guess because I'm a geriatrician, I see a biased subset of people. I have to say most of my clinic patients are in their 60s or 70s, and I see less people in their 80s and 90s, even though dementia is much more common in those age groups. My youngest patients are in their 50s, and some unfortunate people can get younger onset dementia in their 40s or even 30s. Most of those people would be referred to a neurologist quite appropriately.
Thank you.
All right, well, I might push on to the last group of factors that lead to uncertainty in diagnosis, and that's when you're actually thinking this person probably has dementia, but things are still not straightforward for a variety of reasons. So case 8 is an 80-year-old woman living with her husband, and unlike many people who come to my clinic, she walks in and says, I want to find out whether I've got, dementia. And the more common experience for me in my clinic is that people don't have that much insight. This woman has very limited formal education. She started wagging school when she turned 11 and lived in orphanages actually from 12 or 13. She probably has dyslexia, and her medical history is fairly sparse and notable only for 2 cutaneous melanomas which were fully excised. She's had a decline in her memory over several years. When she and her husband drove to a nearby town for one of his appointments recently, she got lost even though she'd been to that town many times before. She has difficulty following the plot of books and TV shows, so she'll read a book one night and then the next night just be unable to remember what happened in the preceding pages. And she's constantly interrupting TV shows to ask her husband what's going on. There's no history of hallucinations, fluctuations in GCS or Parkinsonism. I've lumped those things together because they're diagnostic features of dementia with Lewy bodies. She's independent with her personal activities of daily living, but needs help with following recipes. And she's having trouble using a mobile phone and a new computer, even though she used to be really tech savvy. Having said that, her son has put a Google Home thing in her house and she can use that. So she told me about using Google Home. I did the Addenbrooke's cognitive examination with her. So again, it's a screening test, but I'm kind of using it as a diagnostic test, and she got 80 out of 100. The absolute number is often not super important, although I get a feel for what the clinical relevance of different numbers. 80 is not super low, it's not super high. Her attention and orientation is normal, so she knows what date it is, she knows what day it is, what year it is. Her memory is not very good. So if you did an MMSE, she'd lose 2 points for recall of those 3 words. And in the Addenbrooks, they're also asked to memorise a name and address, and you can only remember 2 components of that after 10 minutes or so. Her fluency is fine, her language is fine, but interestingly, her visuospatial function, which is something that hadn't really come up in conversation, is not very good at all. So she's asked to draw intersecting pentagons, can't do it at all. Asked to draw a wire cube, just draws 2 parallel lines and says that's it. And really can't put the numbers on a clock face, can't put the hands on a clock face. Has an MRI scan of the brain, and I asked for an MRI scan rather than a CT scan alone, because I'm looking for, she's got an atypical presentation, and I need to make sure she doesn't have cerebrovascular disease that it wouldn't be evident on a CT scan, or cerebral metastases. She doesn't have any of those things really. She's got some mild global atrophy, mild to moderate white matter disease, a possible tiny left temporal microhemorrhage that is probably of no relevance. So she's clearly cognitively impaired, and she's got some emerging but fairly subtle functional impairment. So you'd probably say she has dementia, and at most it's of mild severity. But what on earth is causing it? Well, that's not straightforward. It could be Alzheimer's disease, but the classic presentation of someone with Alzheimer's disease is that they have very poor short-term memory early in the disease, then develop some problems with keeping track of the day and date, and might have some subtle dysphasia before other cognitive domains are involved. And it'd be very atypical for someone to have really marked visuospatial dysfunction as this woman does. So it could be an atypical presentation with Alzheimer's disease, but that'd be a surprise. Visuospatial dysfunction is commonly seen in patients with dementia with Lewy bodies, and for that reason, a common history is what all started when he started having trouble navigating around local areas. But it doesn't meet diagnostic criteria for this at present. There are literally no other features of dementia with Lewy bodies present. It's probably not vascular dementia, probably not seeing vascular disease on imaging. And I guess an important thing to note is that clinical picture might change with time. It might become more apparent what the diagnosis is in 1 year, 2 years, or it might become more confusing, to be honest. So that's a good example of a frequent problem I have, where it's clear that somebody has dementia, but it's less clear what's causing it. Next case is a 65-year-old woman admitted to a hospital with acute delirium. Her background is notable for hypertension, osteoporosis, asthma, and past depression. She's been unwell for the preceding 3 months with new atrial fibrillation, for which she was anticoagulated with apixaban, unexplained weight loss, and new anemia. And in that setting, had become breathless, but had attributed that to asthma. She hasn't been particularly forgetful, but has been more agitated, and that was something that her husband really couldn't elaborate on at all. Her medications at the time of her presentation included apixaban, metoprolol, furosemide, paroxetine, thiamine, and denosumab. I'll just mention paroxetine as one of the most strongly anticholinergic medications. It's generally one that's best avoided in older people. Having said that, it's an excellent anxiolytic. So there are many people who've been well controlled with paroxetine for an anxiety disorder for many years. And I generally don't have any appetite for getting them off paroxetine unless a psychiatrist is involved. Usually causes more problems. So she had a workup for delirium, which included an MRI. And that showed what was actually likely an incidental finding, which was a tiny cerebellar stroke that almost certainly didn't cause her delirium. And as part of the subsequent stroke workup, had a transthoracic echocardiogram, which showed severe mitral stenosis, which is probably the reason she has new atrial fibrillation, etc. And whilst an inpatient, she had a cognitive screening test performed by a junior doctor, and they did an Addenbrooks, and she got 55 out of 100. Now, I mentioned this because you probably all get discharge summaries in which somebody's had a cognitive screening test in hospital. I think it's very rarely helpful, actually, to do a cognitive screening test in hospital, because it's never a fair time to do it, and it's hard to extrapolate to what somebody's cognitive best is if you're doing it in hospital. The exception would be if I need to work somebody up for guardianship as an inpatient, I kind of have to do it. So I'm thinking when I see these notes that cognitive screening test really doesn't mean anything, just means she had a delirium. So generally a cognitive screening test performed in the setting of delirium or soon after delirium is of no value. The delirium itself, actually, however, conveys an elevated risk that that person has underlying cognitive impairment. And in this particular patient, the severity of that underlying cognitive impairment was important because we needed to make decisions about whether she would have a valve replacement for her mitral valve stenosis, and we needed to know whether she'd be a candidate for invasive investigation of anemia. So I saw her 4 months later in clinic, and she was much better by that time. So her cognition had subjectively improved. She was going about her day normally. There were no functional problems. A repeat Addenbrooke's was much better. That's the take-home message with 82 out of 100. So she still had some cognitive impairment, but it just wasn't impacting on her day-to-day life one little bit. And so I made a diagnosis of mild cognitive impairment and was supportive of her having whatever investigations and treatment she needed for her other medical problems. So quite remarkably, in the space of 6 months, she went on to have open heart surgery with a valve replacement, had a colonoscopy, and then hemicolectomy for a cecal adenocarcinoma. And that all went well without further delirium. And her short-term, medium-term prognosis is very good. So that's important because those things might not have happened if she'd been labelled as a 65-year-old woman with an Addenbrooke's of 55, which would be grossly unfair. Next case is another highly intelligent, highly educated patient, a 70-year-old retired solicitor who lives alone on an isolated rural property with a daughter nearby and granny flat. He's a keen shooter, has a long history of excessive alcohol consumption. Daughter describes a decline in cognition and self-care over a good 18 months or so. He now eats little, only really in the morning when she's around, doesn't eat much for the rest of the day, drives into town to do the supermarket shopping, but forgets what he was meant to get, and comes home with an inadequate supply of food and will only shower once a week at most with lots and lots of poking and prodding. He gets admitted to hospital in that setting with new atrial fibrillation, decompensated heart failure, acute kidney injury, very unwell, complicated by delirium. And his delirium resolves, but very slowly over weeks. And 1 month later, he remains paranoid, especially in the evenings. So sometime after that, after many weeks in hospital, he had a cognitive screening test anticipating that decisions about where he wants to live might be needed. He might need to go to a nursing home. He doesn't want to go to a nursing home, thinking about applying for guardianship. Has an Addenbrooke's done in that setting and gets 61 out of 100, which is pretty bad. At a time when he's not obviously floridly delirious. Just an example of the degree of cognitive impairment at that time. He's asked to list as many words starting with P as he can think of in one word, and then this retired legal professional could only think of 4 words. And he's asked to name as many animals as he can think of in 1 minute, and he can only think of 2. So it sounds pretty grim. His case is referred to the Guardianship Tribunal for consideration of guardianship. A public guardian is appointed, but only in the domain of services. So they actually can't make any decisions about where he lives. So he is actually ultimately allowed to return home, tolerating a great deal of risk. But when I saw him on a home visit 8 months later, he had been consistently abstinent from alcohol that whole time. He was looking well. He was cognitively much, much better. And to the point where in hospital, he'd been told that his driver's license had been cancelled and that his gun license had been cancelled, but he was cluey enough and cognitively intact enough to work out that, in fact, his license hadn't been formally cancelled. Then he was able to go back to driving and get his guns back and go back to shooting. And that was all entirely appropriate by that point. He'd recovered from, I guess, in retrospect, what was quite severe alcohol-induced cognitive impairment that was luckily quite reversible. Next case is an 80-year-old working farmer admitted with pneumonia complicated by delirium. 2 weeks into his hospital stay, he's no longer delirious, but he's still pretty cognitively impaired, and somebody does an MMSE and he gets 16, which isn't great. His wife is unconcerned at that time, which raises questions about her insight. And she said, well, that's just him. That's what he's always like. He's not interested in those sort of things, by which she means questions about spelling and numbers and so on. He stays in hospital a bit longer. He has another inpatient MMSC and gets 25 out of 30. Everybody involved in his care is happier to let him go home. And he comes to see me in clinic 2 months later. He lives on the farm he was born on, so very proud farmer, and is very much still running the farm, although it's a bit unclear what running the farm looks like for him. And he does get some help from his sons, and they're not available to provide any insight into whether his ability to run the farm has changed. His wife is able to tell me that he's repetitive and forgetful, especially in the evening, but she's very clear that he can still run the farm and he can do everything he needs to do. So there's zero history of functional impairment. I guess I was skeptical and had some doubts about the reliability of that collateral history, largely because when I did some formal cognitive screening, he was, although better than he was at his worst in hospital, still pretty impaired with very, very poor short-term memory. So I felt that even though I had really zero history of functional impairment, it was inconceivable that he wouldn't have some degree of cognitive impairment, and gave him a diagnosis of dementia due to Alzheimer's disease, and gave him a warning shot that his days of driving were likely to come to an end in the next couple of years. And so decisions will need to be made this year about whether he's progressed to a point that means that he can't drive, which will have a huge impact on his ability to do what he wants to do, which is just run the farm until he dies. So I guess a quick list now of factors that lead to uncertainty even when the dementia diagnosis is considered. Recent delirium is important. So we can do older people a great disservice by prematurely diagnosing them with dementia when there's been a recent delirium. How recent is recent? Well, it can often take months to recover from a delirium. I'd suggest at least 2 or 3, which is why I'm, when I'm following people up after an inpatient admission, I'm not too worried if it's going to take months and months for me to see them. They just need to declare themselves as, and they need months to do so. The possibility of the presence of potentially treatable factors impacting on cognition is difficult to deal with. Alcohol is one of the biggest ones. So I see a lot of people who are very cognitively and functionally impaired who drink a lot. Some of those people end up having alcohol-related dementia, as in they stop drinking and there's permanent brain damage. Some of them never stop drinking, and it's really hard to make any conclusions in that setting. Some of them stop drinking, but then subsequently progress in a way that's typical of a neurodegenerative disease. And that's really not clear until they stop drinking. An atypical cognitive profile is not helpful, and reviewing somebody early in their neurodegenerative disease when the clinical picture hasn't had time to evolve can also make things difficult. So loads of times I've seen people and been a bit unclear about what the precise diagnosis was, and it's been much clearer a year later when things have changed. Absence of a reliable informant for a variety of reasons is problematic. Conflicting accounts from different informants, if there are multiple involved, can also be a challenge. Underlying illiteracy is a challenge. And I have to say, a cognitively undemanding life is challenging too. So when somebody has lots of routine and a simple life, it can be difficult to tease out functional impairment, even when cognitive impairment has become quite marked. So I'm getting towards the end, and we're wrapping up very soon and handing over to Irene. Just quickly, do any of those last few cases raise any questions or comments?
There's a couple of questions there in the chat asking about the sort of perhaps a mixed pattern when we're getting ischemic changes seen on CT brains.
I'll make a quick comment about that. That's, as I mentioned earlier, it's very common. So I don't think I've seen a single CT scan of the brain of an older person that doesn't have at least mild white matter disease. That's of no clinical significance. So that's not vascular dementia. If it's really severe, it can be clinically relevant. So that that picture might contribute to a diagnosis of vascular dementia if the phenotype was right. Having said that, if somebody's got the phenotype of Alzheimer's disease, so they've got slow onset of very short-term memory, it doesn't really matter if there's heaps of vascular disease on the CT brain. The dominant neuropathology is probably still Alzheimer's disease. A diagnosis of mixed Alzheimer's vascular disease might be appropriate then. And yeah, so classic vascular dementia is really related to strokes rather than white matter disease. White matter disease has no treatment. It doesn't prompt antiplatelet therapy or even statin therapy on its own. It can just change the phenotype of cognitive and functional impairment. Anything else?
Well, there's a lot more questions popping up there. Probably a whole new topic is driving assessments. We'll
might take a pass on that one.
Sorry, you'll take a pass. Might have to get and then questions which would probably be a whole new topic as well about managing and about the BPSD symptoms.
Again, a whole new topic, but one that's, I think, frustrating to everybody who's involved in care of people with BPSD, especially in the nursing home setting. When you've got somebody with BPSD, you need timely, sensible input, and that's for a variety of reasons often not what you get. Geriatricians often can't see people in a timely manner. Things like DB mass come in and sometimes give some very helpful non-pharmacological advice, but can also, I guess, end up making some suggestions that are kind of ludicrous, like addressing pain in somebody who doesn't have pain, or looking for a UTI in somebody who doesn't have a UTI. So I appreciate that that's a frustrating field, but not something we can cover today.
Just a quick, easy one that someone did mention earlier, where we were talking about the different tests, which might be more a comment, but the use of the kicker for First Nations people.
Yeah, I guess I have to say I don't use it. I use the RUDAS, and I don't use it because the most of the First Nations people I look after in this region are actually attended local schools, can be more literate than many of the non-First Nations patients I look after, and so I don't really see an advantage in those people, and I feel like I would actually be disadvantaging them by using the kicker, a tool that was developed for people in a very different First Nations setting in Northern Australia.
Thank you. I think that's covered sort of my quick question there from Naroda was sort of talking about I think that overlap, and when you've got someone who's got the psychiatric symptoms, a lot of anxiety, etc. Should we be?
That's pretty difficult. Yeah. So there are a lot of patients who meet mental health services first, and then me, and then back again, and it's problematic when it's a mixture of everything.
I think we've covered them all, and I am just conscious of time. We could ask you questions all night, I think, on this topic and on dementia, but thank you very much. I think I particularly like the way that you put things into those three different categories of why the diagnosis can be difficult. So thank you very much, and there's quite a few comments
for having me.
Thanking you. And
probably a good time to pass over to Irene, who's, I guess, done a huge amount of work capturing many of the things we've been talking about into an easy to follow pathway.
Yeah, so we got you there, Irene. So just again, for those who weren't there at the beginning when we were talking about the health pathways, Irene is a local GP in Orange who's been working with Phil to develop the health pathways for dementia and some of those other things that Sophia was talking about at the beginning. So have we got you there, Irene?
Yes, I'm here. Hello, everyone. Good evening. Thank you so much, Phil, for this enriching night. It was very, very informative for everyone. I think we will be looking forward for another session or possibly sessions with you. At this point, I am excited and pleased to share with you of our cognitive impairment health pathways that we have been developing with the rest of our energetic team and with the generous help of Dr. Phil Butler and Professor Louise Wade. These are the respected geriatricians who have been providing services and support to our area. So as it was mentioned earlier, our aim is to provide localized and concise and quick resources to our GPs here in Western New South Wales regarding approach to cognitive impairment at point of care. Now, we're hoping to go live in the coming weeks, as mentioned earlier, and I'd like to give you a sneak peek. I'm going to share you my screen on how it looks like when it appears on live in our Health Pathways page. So, let me just open this one. So as you can see, this is the pink version. Dr. Ivy Chua showed us earlier the live version, which is like it's color blue. Now for draft purposes, that's my part. It's in color pink. So just showing it to you when it goes live, the pink one would appear as color blue, but you would see here at the left side, it will be having this older adults health, adults health. And then primarily we are doing the cognitive impairment suite. And within that suite we have the behavioral and psychological symptoms of dementia and cognitive impairment, driver assessment of patients with cognitive impairment and dementia, and medications for dementia. So this one, as you scroll down through each page when it goes live, you will be seeing some links to be able to help and guide you, say, for example, with specific like diagnosis, some tests that we need to perform, what referrals that we need to take on, and some other helpful and useful links for us doctors and for the patients themselves. And just be mindful, towards the end of each page, there will be a note, there will be a section there which is called request. That is the referral page wherein it will lead us through to some possible forms that we need to utilize if we would like to request the assistance or the service of our local geriatricians. I'm really excited to have this one go online, all go on live in the coming weeks, and for sure you will be informed once everything has been gone on live. Do you have any questions so far at this point?
No, looks good.
Yep. So these are just the 4 suites, and who knows, like in the months to come, we will be able to develop much more depending on the needs in our area. But if you have any questions, feel free to send us a message at PHN, and we'd be more than happy to help you. And you could even like send feedback through the page as well. Thank you.
Thank you very much, Irene, and a big thank you to you for putting up your hand to help to do that. So, yep, imagine it is a lot of work. So once again, thank you for everyone for being here and for your input, and to all of our speakers this evening, particularly to Phil. We found that very useful, and as I say, we could get you back again for several more sessions. We do appreciate your time, and certainly learning about the health pathways, and we look forward to seeing those come online. Just on your screens now, you'll see the QR code to do your feedback. We'd love it if you can do that, and if you can put your suggestions for future aged care sessions, but really any topic that you would like, and we'll aim to get speakers for you. If we've just got Katie or Liz there, can I just clarify something to on the CPD that we'll get for this? Does that automatically go through, or people will need to submit it with their certificates?
So the CPD hours will be allocated to people who've attended, as long as they have their correct name listed when they join, and correct email. We'll be able to track who you are and be able to allocate your hours for you and send you a certificate.
Thank you very much, Liz. All right. Good night, everybody, and have a nice weekend.